Thank you. So I'm in the land of glued IOLs. So I decided to steer clear of this and talk about scleral sutured IOLs instead. My financial disclosures with no relevance. So how can we scleral fixate? We can do it by suturing directly to the sclera, or we can suture a pre-existing capsular tension ring which has been implanted at the time of the cataract surgery, or we can insert a capsular tension segment, or suture a pre-existing capsular tension device. So what suture material should we use? It should be permanent, and we know from the literature that polypropylene 10O hydrolyzes over 5 to 10 years and is not really suitable today. We would prefer to use a 9O polypropylene, or what I've been using most commonly is polytetrafluoroethylene, or we call Gore-Tex, and the suture I use is CV8, which is 7O Gore-Tex. It's off-label use for scleral fixation, but it has had excellent longevity, and this is the reason why I'm using it. So I'm just going to show you this technique, which has been published in the British Journal of Ophthalmology, because I'm going to use it repeatedly so that you can understand what this is about. So we're going to use this as a suture snare to help us in our surgery. And we use a 27, or today I've been using 27 more than 26 gauge needles. And we thread Gore-Tex 7O, which has been cut, a short segment that has been cut, and we thread it through from the bevel point. And then we capture the end with a tuberculin syringe so that it does not slip out. And if the suture trails behind, it doubles on itself. So we can then insert this at the scleral fixation point with this suture double on itself, and we can extend it next with a Coughlin hook. And this then forms a snare, which we thread on a suture that we wish to bring in from the incision point, preloaded onto a capsular tension device here to the scleral fixation point. This snare will then loop on the suture, and as we pull it out from the sclera, it then brings the suture along with it, and we have had a nice transmission from this end, from the incision to the scleral fixation point, and this is then repeated for the other end. So this is what we call a suture snare. I'm going to show you a common scenario that I see. So this is creating the snare, just threading it, and it really takes seconds to do, okay? And we're going to use Hoffman pockets in order to spare the conjunctiva, so dissecting from clear cornea backwards into the sclera, marking a 1.75 mm posteriorly, and I'm then going to create 2 paracenteses. All right, so you'll see here that I'm just going to directly suture behind the haptic and the capsular bag. So that's a snare that carries a free suture through. I'm repeating this with the needle above the haptic and threading the other end of the free suture and pulling it out at the scleral fixation point. I'm going to repeat it for the other side. So this is actually completely loose now. This is passing behind the haptic in the capsular bag. This is the loop of the snare, which then draws the free suture to scleral fixation point. And then we're going to do this with the needle above the haptic. And so now we have this suture which is looping around the haptic. And we then retrieve the sutures from the Hoffman pocket with a Sinski hook. And we're doing it for the other side as well. And once we have these two out, we're going to look at the centration of the IOL as we apply the tension and throwing a 2-1-1 kind of a knot. We don't want a big bulbous knot there that may erode. And these pockets need to be deep enough. But you can see this is something that we can do very easily. You don't need even infusion. And it's important to note how you apply these sutures, one above, one below, and then we have the knot there. And the other side should be opposite it so that it's an anti-torque force so that we do not rotate this IOL. I'm going to show you another case here, and this patient has had a toric lens and also a capsular tension ring placed in, right? So this lens is really freely dislocated posteriorly. Going to remove any vitreous, very important, before you pull. You have to clear all the vitreous attachments. And again, we're going to use the suture snare. But this time, we're going to use a different suture. And this is described by Sergio Kanabrava from Brazil. We're going to use Gore-Tex, we're going to use Proline 6O, one passing below, and in a similar fashion, the needle now passes above at the scleral fixation point of 1.75 mm posterior to the limbus. And this is 6-0 proline that is threaded one above, one behind. And we do the same with the opposite side. Okay, so we have marked it. And because it is stiff enough, it can thread through a 27 gauge needle. And we do the same with a 6-0 proline. And so now we have the sutures looped above, from behind to above, and we have it secure on both sides. And this is the time we're going to use our cautery. We're checking to make sure it's well centered. A peripheral iridotomy is created here. And we're going to create a flange with, in this case, is that low temp cautery. And the tension is important. You apply the tension there, check the centration again. Once you're happy with the centration, then you flange the other end so that you have actually spared conjunctiva, and we have not had to do any dissection into the sclera at all. You do it the same for the other side without adjusting the tension any further because your lens is well centered. And then you make sure that this flange is buried inside the sclera and you pull the conjunctiva over it. So this is one behind the other, all right? So I'm going to show you another case here. This patient, I had done the surgery many years ago. I had to put in a capsular tension ring because the zonules were weak in one sector, but over time, this lady returned because her lens had dislocated. And you can see here, this is doing vitrectomy first through the pars plana with a single port there with the anterior chamber maintainer. I use a 23 gauge here. And once you hold on to the IOL, you must not pull so that you do not apply traction on the vitreous. And you can see because this had flipped totally, I had to flip it around, making sure that I had cleared all the vitreous. And this again, you can see is a toric lens. So I'm going through the capsular bag from behind both the tension ring and the IOL, which is a single piece, which I'm not going to explant. I want to preserve ability to correct toricity. Right? So the other goes above. This is a suture snare using Gore-Tex 7.0, also known as CV8. Now, once I've done that, I'm holding on to the IOL with the CTR, and it's useful, you know, if you have loose zonules. If you have implanted a CTR at the time of the first surgery, you can actually suture around both the haptic as well as the CTR to give a more secure hold of the IOL. So again, above now with a free suture. So this suture now loops around the IOL, and we've actually got the toricity aligned to her original axis to correct the astigmatism correction that she enjoyed all the years before the lens subluxated. Adjust for the centration of the IOL and do a 2-1-1 suture and make sure that your tension is appropriate so that the IOL remains centered after you've finished your sutures, and then you can give this patient good vision. Now we're going to look at this other patient who happens to be an orthopedic surgeon. He had his surgery done 4 years prior, and he's got a toric lens, quite a high diopter of astigmatism, and the surgeon who referred wanted me to preserve this lens. So you can see the toric marks aligned with the mark of the axis it should be repositioned to. In this case, I'm hooking up the bag, right, with iris hooks on either side of the axis, where I'm going to place a tension device to support this area of the capsule. Right, this has given way, so I'm putting in a capsular tension segment, which I've preloaded with the Gore-Tex 7.0. I've removed Somring's ring, part of the lens material there, so that this capsular tension segment can fit in comfortably. Right, this is actually a 5 mm length, so it needs at least 4 clock hours of dissection. That's important to know, so that this will sit nicely inside the capsular bag. And you'll be surprised, 4 years after the surgery, we are still able to open up this capsular bag, insert a tension segment in, and then use a Hoffman pocket to secure this IOL. This is another patient who has got a multifocal toric lens, and you can see this is a plate haptic. So it gets even more difficult to fixate this. And the whole lens bag is free floating. So again, we've marked the axis that we want to reattach this to, the alignment marks here, and we use iris hooks, right? Sometimes we need to hold on to the capsule just to get the hook on. And once we've got the hooks in place, we know the alignment is appropriate, we can then proceed to remove any vitreous. I'm going from behind because this plate is so huge, and I've got it secured in place, and we make sure that with the aid of triamcinolone that's diluted to 50%, we remove all vitreous. We don't want to have any complications with the retina, very important. And then we're going to open up the capsule bag so that we can secure the IOL. So in this case, I'm going to put a tension segment here where I've cleared up the cortex here, so it's dissected free, and this is the point of fixation that I've chosen for the appropriate axis placement. And again, we're using the suture snare with a 26 gauge needle. In this case, you can use a 27 gauge needle, one above and one behind, and we can then retrieve these sutures from the Hoffman pocket using a Sinskey hook. We do the same for the opposite side. These procedures do take time, but really they give very rewarding outcomes with very satisfied patients. So you adjust then the tension to make sure that this IOL is well centered after having gotten the alignment right from the outstart of this multifocal toric lens. So I'm going to show you another case here where things didn't go quite so well. All right, it looks like it's so simple that we can always open up the capsular bag and put in the tension segment. Well, I thought I could. It looked like another case of toric monofocal IOL that I had shown earlier. So here we are. We knew exactly which axis we had to place this at. I hooked up the bag, right? Put the alignment, looked at the centration, was happy about it. And I was happy talking, and then suddenly I saw this line here. Okay, so be very careful. You think that everything is going fine. The bag looks like it's opening, but it's actually ripped the capsule. So what is plan B? So I'm still going to fixate this. In fact, the surgeon assisting me, this is his cousin, so wasn't going so well for me. But here I'm using the ASI anchor by Ehud Asia, made by Hanita lenses. And this actually, you can see, hooks onto the anterior capsule rim and does not require the equator of the bag to be intact, right? And this device, the stem of the T goes above the capsular bag. So we don't need to dissect that much either. It's just a very short segment that you need to dissect to place this device to support the bag, although the support here is much narrower than what you can achieve with the tension segment. So again, using the suture snare, we slip this in, right, so that the anchor is against the capsule rim, and with the Hoffman pocket here, we retrieve the sutures, and then we can get this lens again well supported and in good alignment for this toric IOL. I'm going to show you this last case here. This patient I had done several years ago with tenoproline. All right, she was having a 2-point fixation with a toric lens implant. And what you see dislocated here is not just the IOL within the capsular bag, but also a capsular tension ring, a Sioni 1L capsular tension ring, and a capsular tension segment. So there are 2 points now to fixate, all right? And I have to align the axis. Okay, now how are we going to thread this? Now just have a look. I'm extending the suture, I'm placing the ring over the suture, and I'm threading the cortex through the eyelid. Okay, now there's one little trick here. When you do this, the cortex is quite broad and thick, and your forceps cannot grasp it through the eyelid because it cannot open widely enough. Okay, so what you need to do is before you grasp it through the eyelid, you need to squeeze that suture so that it presents a narrowed kind of profile. Watch it again. I'm going to put the eyelid over it, and I'm going to pull it through. Okay, so this is slightly crimped so that it's narrower than the actual suture normally is, and that allows you to just grasp it through the eyelid of an implant that's already in the eye, the tension segment that's already in the eye, and then you can again refixate through these eyelids, and you can spare the bag, all right? So you don't have to put your needle through this bag, and you can nicely support this, all the devices within the capsular bag nicely in place and correct this lady's astigmatism once again. So in summary, Gore-Tex 7.0 is really a user-friendly suture for scleral fixation, and I encourage you to use it. It's really very strong and it's flexible and it knots very easily. You can anchor it, the IOL directly to the sclera, or you can use through the capsule, or you can insert a device like what I've shown in many cases. And also very useful today, available to us, is the Kanabrava technique, which uses flange polypropylene 6.0, which spares the conjunctiva. Thank you very much.